start off the presentation, we're just going to go through a little bit of the basics. Um, and I apologize if this is more basic than you need, but just want to make sure we can kind of go through everything for every level, okay? So to start out, we'll just go through a little bit of the background, some of the risk factors, the types of kidney cancer, how it arises, the staging, the treatment of localized kidney cancer, and then the medical management and kind of future directions of treatment. So to start out, in terms of the background about kidney cancer, so kidney cancer arises when you have cells that grow uncontrollably, and sometimes they can stay localized, or sometimes they can spread through your blood. And those can go to distant parts of the body through your bloodstream. And now when we think about classifying the different types of kidney cancer, we have a type called renal cell carcinoma, and the most common type of renal cell carcinoma is clear cell kidney cancer. There's other subtypes that I'll get into in a little bit called papillary and chromophobe. There are also some more benign kidney cancers that we can usually watch with surveillance. And then there's a kidney cancer that we won't necessarily go into today since it's mostly present in children under the age of 5, and that's called a Wilms tumor. And now, when we think about how we work up and diagnose kidney cancer, unfortunately, we don't really have a screening test that we use like a colonoscopy or mammogram that you normally get every year. And the reason for that is because oftentimes kidney cancer is relatively slow growing. And so many early stage are just found incidentally on imaging or a workup for another medical problem. So when we think about doing a screening test, we usually want these to improve outcomes in the general population. So that's why we generally don't do screening in patients who are average risk. Now, what are the most common symptoms? So the most common symptoms actually no symptoms at all. But if it has spread or is causing symptoms, you can present with blood in your urine or what we call hematuria. You can have some weight loss or low blood counts, which is what we call anemia. Flank pain, which is pain on your back where your kidneys are located. And sometimes you can have bone pain or loss of your appetite. And when we think about what kind of tests we would do to work up for a diagnosis, the first step would be going to your doctor to see and get a better history and physical exam. We'd oftentimes check your blood counts, check what we call a comprehensive metabolic panel, which is checking your kidney function, and also checking a urine analysis. Oftentimes the next step is also getting an ultrasound, and if there's anything concerning on the ultrasound, we'll then get a CT scan or MRI to better get a look at the extent of the kidney mass and get a better and clearer picture. If the cancer has spread to other locations, we'll sometimes get imaging of your chest and then a bone scan as well. Now, for risk factors, we have risk factors that we call more modifiable, and those that are inherent to your genetic makeup. And some of the modifiable risk factors are smoking, and they've shown that men who smoke actually have a much higher risk than females who smoke. Obesity is also a risk factor, along with high blood pressure, kidney disease, and some environmental exposures like chemicals. And family history in terms of those more hereditary syndromes that we think about, that's about 5 to 8% of kidney cancers. And those would usually present at a younger age if you have multiple family members that also have been diagnosed with kidney cancer. And some of the genes that are linked to these are called what we call von Hippel-Lindau syndrome, Birt-Hogg-Dubé syndrome. And we would get a better history from you and oftentimes refer you to one of our genetic counselors at the cancer center. So anytime that you go see one of your doctors, we'd go through that history with you to see if there's any concerning that we think that that's necessary. Now, in terms of the types of kidney cancer, the reason that we kind of oftentimes have to classify kidney cancer, we usually classify it based on what it looks like underneath the microscope. And that's just what that histologic subtype means. We oftentimes use clear cell, or RCC is the abbreviation that you'll oftentimes see, and then non-clear cell. And those are those less common subtypes that we think about. The other thing I wanted to mention is sarcomatoid features. That is something that if you have a pathology report would usually come accompanying if you did have your kidney removed, and those oftentimes indicate a more aggressive disease, and it can present in any type of the subtypes of kidney cancer. Now, for staging, there's staging that we use based on imaging and staging that we use based on what happens after surgery, and that's what we call your pathologic staging. Oftentimes, when the tumor is larger than 7 centimeters, that's a stage 2. Sorry, greater than 7 centimeters, stage 2, and less than 7 centimeters is stage 1. And patients have a very good survival rate in those earlier stages. When it's a stage 3, that's usually when we have it go into the major veins. And oftentimes, a stage 3 can also include lymph node involvement. And stage 4 is usually when it's spread to that kind of surrounding gyrus fascia around the kidney and then other areas of the body. And in terms of management, you'll normally have a whole team of doctors who are taking care of you. That includes doctors like Dr. Rapold, myself, sometimes a radiation oncologist as well. And then oftentimes a kidney doctor if you have underlying kidney disease or um, we need to have any additional input from them as well. All right, and I'll pass it over to Dr. Rapold.
All right. So for most people that are being diagnosed with a renal mass, at least 70% of the time, people are being diagnosed with a kidney cancer. It's going to be confined to the kidney. So the first person that you would meet is a urologist like me in most cases. And when we meet in clinic, a big part of the discussion involves this, which is that we could kind of organize all the different options for managing a tumor in the kidney into these 4 categories. So that would include active surveillance, which is where we just kind of watch it closely and see whether or not it grows. Ablation, there's a couple forms of this, but basically that's a means of destroying the tumor with non-radioactive means of energy without removing it from the body. And then there's radiation, which is an effective treatment. And then there's surgery, which is what I do. So a note on active surveillance. I think the best data that we have on this comes out of a national registry, several institutions involved. This was started out of Hopkins in 2009, I think. So they recently published some 15-year outcome data. And what they did was they basically enrolled a bunch of people that had small renal masses, which they defined as being less than 4 centimeters. And nobody was randomized to any treatments here. They ultimately decided on whether or not they were going to have it treated or whether they were just going to watch it. And that was a decision made between the patient and the doctor. But they followed these people over time. And what they found was that it's very safe to watch small renal masses. The majority of them end up not growing. And this has even made it into our national guidelines as urologists. For tumors in the kidney that are 2 centimeters or less, the preferred initial management strategy is let's just watch it for right now. Whether or not it's actually a kidney cancer, the majority of them don't grow. And as you can see here from some of this data, for tumors of this size, after 10 years of follow-up here, about 25% of people ultimately received some form of treatment. But nobody that was being watched had any kind of disease progression or spread to other parts of the body. Okay, so it's a very safe strategy. The commonly used triggers for intervention on this protocol and what we do for the most part in our practice is when we're watching these tumors, if they're growing more than 0.5 centimeter a year, or once they get up around 4 centimeters, that's when we tend to pull the trigger. But this whole concept of active surveillance is basically saying, let's watch it, and then we will treat if it does start growing. And one question that people ask a lot is they say, well, if you wait to treat my tumor until it's bigger, are my outcomes going to be worse? Now, we don't have an ironclad answer to that, but they did look at this a little bit. Is this center button? I'm guessing it's this green button is the laser on here. Sorry, I just haven't used this control before. So this slide down here looked at people that had surgery or ablation up front when they were initially diagnosed. That's the red line. The black line are people that had delayed intervention. So they had their tumors watched for months or years before they had their surgery or ablation. And there was no difference in how they did over the following 6 years. So in other words, there wasn't a price to pay for waiting to treat it. For ablation, there's a variety of technologies that have been used over the years. The common denominator here is that these historically have all been percutaneous approaches. That means that something is inserted through the skin, and then some form of non-radioactive energy is delivered to that tumor. The most common modality that's used nowadays is called cryoablation. And so that's where they basically freeze the tumor. They generate an ice ball, and they can watch this ice ball grow under live imaging, usually ultrasound, or sometimes they're using CT. And then they let it thaw, and they usually freeze it a second time. And it turns out this is a pretty effective way of treating small tumors. They got to be in a good location, and they got to be a small enough size. But if in appropriate selected candidates, this is probably some of the best data we have. It was a large cohort of patients out of the Mayo Clinic, and they were comparing, they just looked back in their records, all the people that had surgery for these small tumors under 4 centimeters, and they compared them to people that had ablations done, either radiofrequency ablation or cryoablation, and the outcomes seemed pretty darn similar. Statistically, there was no difference, okay? The one caveat here is you got to have a good window for it. It can't be too close to the center of the kidney, because there sometimes it can be too warm to generate the ice ball. And in general, when the tumors get larger than 4 centimeters, the effectiveness does start to go down a little bit. Okay, but this is an excellent treatment option for people that are looking to avoid surgery and have a favorably located and sized tumor. This is a newer technology. It's not currently available for widespread use. We're participating in a national clinical trial right now on this. It's a technology that is currently FDA approved for the destruction of liver tumors. It's pretty cool though, and we're all very excited about it. It's called histotripsy. It's basically a technology that uses ultrasound waves that are focused from a probe outside of the body that converge on the tumor inside the body, and they generate little bubbles, little gases that are dissolved in all body fluids, come out of solution. These bubbles expand and collapse, and mechanically this just destroys the tumor cells without changing the temperature at all. And nothing has to be inserted into the body during this procedure. So again, it's a completely non-invasive form of tumor ablation. There's no damage to the overlying or surrounding tissues. So far, it's had an excellent safety profile in liver tumors. In fact, the university has a device, and there are liver surgeons using this on a regular basis. I think ultimately, this will be used routinely for the treatment of kidney cancers as well. But as of right now, it's still part of just a clinical trial. Radiation. This is not used an awful lot nowadays, but there's been a resurgence in interest. I think it's a very effective treatment modality. Historically, it got a bad rap in kidney cancer because the normal way that radiation is delivered, for example, radiation is a common way in our line of work that prostate cancer is treated. And it turns out that if you deliver radiation in little doses, many times over, every week, for many weeks in a row, like you use to treat other cancers, it doesn't work very well on kidney cancer. But if you administer larger doses in fewer fractions, so just a few treatments or sometimes just one treatment, it's a very effective form. Now, there have been several clinical trials, and I think there were 2 or 3 more published in just the past few years. This has local control rates exceeding 90% at 5 years. And what that means is that basically the tumor either shrunk or didn't grow any bigger with 5 years of follow-up. Nobody exhibited any signs of disease progression, distant sites of disease, metastasis. There's a pretty low incidence of serious side effects. And for the most part, it's pretty well tolerated. I think usually fatigue is the most common symptom that people report. In actual practice nowadays, most of the people receiving radiation, they are not a good candidate for surgery, but they have a tumor that's too large for us to just comfortably watch. So they need some other form of treatment, and anybody can tolerate a little bit of this. And there's surgery. So there's a couple different ways we talk about how we approach kidney surgery. The first is making a decision about whether or not we can do it through little incisions or big incisions, okay? Thankfully, most of the kidney surgery we do nowadays is through small incisions, laparoscopic, and pretty much all of us do this surgery with the Da Vinci robot, so robot-assisted laparoscopic surgery. And this was just a little thing here showing that there's a couple ways to do the robotic surgery. Most of the time it involves 4 to 6 small incisions on the belly like this. Sometimes we approach it from the side with these little incisions above the hip to go up into the back of the abdomen. But for larger tumors or tumors that are a little more dangerous to take out, we still resort sometimes to more conventional open surgical techniques when needed. And then the other decision we have to talk about is, do we need to really remove the whole kidney, or can we just cut the tumor out and leave the rest of that healthy kidney there? This is a complicated decision process in some cases, but basically it boils down to our decision on whether or not the size of that tumor and its location within the kidney would allow us to safely perform this partial nephrectomy that you see depicted here on the right. So for this sort of tumor, I would agree with the picture here that that's a good candidate. You know, it's away from all the blood vessels and the dangerous stuff here. It's very superficial. So what we can go in and do is we temporarily put clamps on these vessels. We can cut out the tumor and sew the kidney back together. And in most cases, people have really no significant change in their kidney function after this surgery. And oncologically, it's just as effective of a surgery as removing the whole kidney, as long as we get appropriately negative margins. But sometimes tumors are just too big, or they're in a really bad location, and so we need to remove the entire kidney, and that's called a radical nephrectomy. And this is just to show you a few examples about how this decision can be complicated to make. So here's an example: small tumor located superficially on the front side of the kidney. Very straightforward for a robotic partial nephrectomy. Okay, that would be a very easy tumor to remove surgically. Now you take a tumor that's about the same size and you stick it right in the middle of the kidney like this one. And these are the blood vessels right here coming in and out of the kidney. Sure, we can give that a shot, but that's going to be a high-risk surgery, meaning we may end up having to take that whole kidney out. It's right in the center. It's very hard. We want to get negative margins. We don't want to leave any of the cancer cells behind, and we got to leave them with meaningful kidney. This is an example. Tumors, or I'm sorry, going back to this one. This is a more aggressive form of kidney cancer that we see in about 10% of cases, where the tumor can actually grow inside of blood vessels in the body. And this tumor here in the left kidney is growing through this renal vein, and it's growing through a large vein in the back of the abdomen towards the heart. Now, this is sometimes done robotically, but safest way most people would do this surgery, that's via an open approach to remove that. And outcomes are still good with that approach. And this is an example where, again, it's hard to conceive of a way we can cut out that tumor and leave someone with meaningful kidney left, but it's not that big, so minimally invasive approach there can make sense. And then just one last note here on the effectiveness of surgery. We've got lots and lots of years of data on studying the surgical outcomes, whether we do partial nephrectomies or total nephrectomies. And you can see here for early stage disease, in particular stage 1, stage 2, stage 3, very good outcomes here. Most cases end up cured with surgery if we catch it in time and it's still confined to the kidney.
Okay, so when we think about where I kind of come into the picture, or a medical oncologist, I just want to briefly kind of go over some of the treatments in terms of treatment options, and then I'll go into the specific indications of when and the treatment options that we have. So like I mentioned before, we mostly use this in advanced or metastatic kidney cancer, and oftentimes this includes immunotherapy or targeted medications. And when I say advanced kidney cancer, I mean sometimes we give immunotherapy, what we call after surgery or adjuvant treatment. And oftentimes we use a combination of medicine. So usually either combining two immunotherapy drugs together or a combination of the targeted medication along with a immunotherapy and tyrosine kinase inhibitor, which is a type of targeted medication. Now, the way that these medications work is that immunotherapy or drugs, I'm sure you've seen commercials on television for Keytruda or Opdivo, and they work by basically exposing proteins on your cancer cells that make them more recognizable. So normally your cancer cells are kind of evading what we call or escaping your own body's immune system. And so your immune system isn't able to recognize them as being foreign and go attack them. So we give these immunotherapy treatments to make them more recognizable, and then your own body's immune system or T cells can go and destroy them. The other way that our targeted therapies work is, and they work pretty what we call synergistically, and they work together, is they basically block pathways that allow for tumor growth, spread, and resistance. And that's through sometimes blocking pathways that allow for blood vessels and growth. And one of the things that we'll do oftentimes, or we get referrals from our urologic oncologists, is when someone's considered to be a high risk of having their kidney cancer come back. And usually we use certain factors when we kind of consider giving immunotherapy treatment for a year after surgery. And that includes certain features, we call that sarcomatoid histology that I mentioned before, certain grades or how aggressive the kidney cancer looks underneath the microscope, along with the stage. And they did a trial that they published called the Keynote 564 trial, and they used that drug that you've probably seen on television called pembrolizumab. And they included patients that had both a small amount of metastatic disease that was resected, along with that intermediate or high-risk disease after surgery. And these treatments are often given for a total of 1 year, and they're given every either 3 weeks or 6 weeks. And they showed that this medication can improve what we call disease-free survival and overall survival. Now, trying to extract which patients have the most benefit, we're still trying to figure out because every treatment has its own side effects. So about 1 in 5 patients that get these medications have side effects. Most times the side effects are mild, but they can potentially be severe in some patients. Now, when we think about patients that have metastatic disease or kidney cancer that spread to other parts of the body, most oftentimes it will spread to the lungs, to the lymph nodes, to bones, and sometimes the brain. We use a risk stratification system called the IMDC criteria, and that basically allows us to determine how high of a risk you are and how aggressive we need to be with your treatment. Sometimes patients even that have kidney cancer that's spread, we can sometimes still even consider watching. Now, the certain criteria that we use are usually based on lab parameters, along with the time to when you need to start treatment. Now, before we had our combination therapies, the survival for some of these patients was not very good. It was about 8 to 10 months. But now we have several trials that I have. It's the green one. They've done more recently, and we've used the combination of 2 immunotherapy drugs called ipilimumab and nivolumab, along with the Keynote 426 study that combined Keytruda with one of those targeted agents called axitinib, along with another clinical trial that used nivolumab and cabozantinib, and then pembrolizumab and lenvatinib. And you can see those are the what we call the combination therapies that include the immune checkpoint inhibitor and targeted therapy. And then this one here is that combination immunotherapy and immunotherapy treatment. Now, I'm sure you're probably wondering which one is the better treatment option out of all of these. And I think that's a question that we don't actually know. There are certain things that we kind of take into consideration as to how much cancer that you have and how fast those cancer cells are growing, along with some of the other medical problems. If you have those sarcomatoid features, we tend to favor giving this immunotherapy and immunotherapy combination. If you have a cancer that's growing really fast, those targeted therapies work very quickly to keep it under control. And so we tend to favor one of those three regimens. I think every probably oncologist that you would meet or go in to have a consultation with would probably tell you a different regimen. And usually all of the regimens we aren't able to compare because they included different patients in each of the trials. So we tend to try to avoid doing what we call cross-trial comparisons. But so they're all pretty much considered equivalent, or what we call frontline treatment options. And you can see that any of the treatment options, for the most part, have really improved the MOS, just means your median overall survival. We have patients now that are living years with these treatments. And those are within each of those risk groups, that favorable, intermediate, and poor risk group that we used from the IMDC criteria. And you can see also that patients we even have patients that have a CR, means a complete response, where we no longer see any disease on scans that are done for what we call your restaging scans. So some patients are living, and we don't quite know exactly when we should stop the treatment because patients are now living much longer than they had been in the past. Now, one of the other thing I think is important and to kind of go over some of the side effects that can happen with immunotherapy. When we're revving up your body's immune system to go and attack the cancer cells, unfortunately, there's no specific markers that we can kind of use on the cancer cells. We're just revving up your own body's T cells, and those can attack any organ system in your body. And so when we think about the most common side effects that patients can have is sometimes fatigue, itchy skin, diarrhea, rash. They can affect any one of your endocrine organs, including your adrenal gland, thyroid, and sometimes even your pancreas, leading to diabetes. They can affect your kidney and liver and lead to elevated liver enzymes or worsening of the kidney function. And more often than not, they're very mild, and we can manage those with supportive medications, whether that's a topical steroid cream or an antihistamine to calm down or help with that itching. But sometimes they can be a little bit more severe, where we have to hold the treatment and make sure that you're getting better before we resume. And rarely we'll have to stop the immunotherapy permanently or give you IV steroids to try to calm your body's immune system down. And occasionally they become so severe that you'd have to get admitted to the hospital. Those more severe life-threatening side effects are, like I said, rare, but they can happen. So when we think about the treatment and future directions of treatment in kidney cancer, unfortunately, there aren't a whole lot of newer targets. I'll go into one of the newer ones in a later slide. And we're also trying to come up with better blood tests and biomarkers to predict how well patients will respond to treatment. Because like I mentioned, there are a lot of different options, and which patients should get which treatment and which patients do better with which treatment options is still quite unclear. They're also, like I said, trying to develop new targets. And for the most part, they've done several trials where they've tried to see if giving treatments before surgery, like in breast cancer, to see if that's been improved outcomes. And so far, we haven't really had a great amount of data. And then those less common kidney cancer subtypes, because they aren't very common, we haven't had a whole lot of research on what the most effective first-line treatment options or even subsequent options are for. And then the last thing is the diet and your gut microbiome that I'll also go into in just a second. Now, one of the newer targets that we've had in kidney cancer treatment is the and what we call our HIF2 alpha inhibitors, and that's your hypoxia-inducible factor 2 alpha. And one of the drugs that recently was approved in 2023 is called belzutifan, and that's a HIF2 alpha inhibitor that was originally approved for one of those hereditary syndromes called von Hippel-Lindau syndrome. And they realized that about 90% of patients that have clear cell kidney cancer actually have this mutation that's not an inherited mutation, but it's a mutation that they develop that's inherent to their tumor. And so now we're having a lot more clinical trials, as you can see down here, that we're trying to use this specific target in combination with the known targeted medicines like immunotherapy and those VEGF TKIs. And so I think having this as a newer target and ways that we can maximize those treatments for patients is really going to be the next era of where we kind of go with some of the newer frontline and adjuvant trials moving forward. And the last thing I want to talk about is some of the other future research that's been going on with immunotherapy treatment. One of the, our diet is has a huge impact on our overall health. And they've done studies in melanoma, which, similar to kidney cancer, also has a lot of what we call a very robust tumor microenvironment, meaning there's a lot of inflammatory cells that help to stimulate your immune system. And so they did a study in which patients who had a lot of dietary fiber intake had improvement in their progression-free survival compared to those who didn't eat as much fiber. And so now we have a trial open now where we're just even at the Wilmot Cancer Center, where we're trying to better understand, is this a potential biomarker that we can use and see if this can impact and improve our treatment effectiveness moving forward. So what questions do you guys all have? Yeah, go ahead.
You have to go through the
The treatments?
treatment, right?
So the question was, how long do you have to go through for the immunotherapy treatments? That's a very good question. So when we give it after surgery to reduce the risk of the kidney cancer coming back, that's usually for a total of 1 year. When we give it in metastatic disease, usually it's about 2 years. Some patients decide to continue their treatment indefinitely if it's still working and they're tolerating it without any side effects. We don't have quite a full understanding of whether or not it's beneficial to continue longer. But for the most part, usually we'd say about 2 years or longer for when it's spread to other parts of the body, as long as it's still working.
Metastatic. Yeah, well, my case, like kidney cancer, the metastatic brain tumor occurred about 10 years after I had my kidney removed.
Mm-hmm.
I'm currently going to immunotherapy treatment.
Mm-hmm.
But do we wait 2 years and stop, come back again, or do we continue on?
That's also a good question, so I'll repeat it for the people online. So if the kidney cancer, if you stop the immunotherapy treatment after 2 years, will the kidney cancer come back? That's also a good question that I think we always have to have with our patients. Usually is there's no evidence of disease on a CAT scan or a bone scan or any type of imaging. Usually that's a discussion I think that we have to have with our patients about the risk and benefits. Usually I would say some patients or most patients would want to continue because we don't quite know the answer to that just yet. So as long as you're tolerating okay, then most patients opt to continue. But if you're having side effects, then I think it's always a good conversation to bring up because I think you always have to balance, right, the side effects of the treatment that you're getting with the quality of life, especially now that our kidney cancer patients are living a lot longer. So.
One question online. It says, are cysts on kidneys an introduction to cancer?
Generally, cysts on the kidneys are relatively common to see. Usually as long as they're relatively small and stable in size, they shouldn't increase your risk of having kidney cancer.
Any other questions from online or in the crowd here? Well, thank you both so much for this wonderful talk. We really appreciate you guys coming out. We can give you guys a round of applause.
Thank you.